Myself Dr. Rahul.
Second year postgraduate anesthesiology, Shandra Medical College.
In this video, I am going to show you how to manage a general anesthesia case, how to intubate a patient, how to extubate the patient safely under the guidance of Dr. Madhusudan Reddy sir, my professor.
So, before going to the general anesthesia case, we have to check the anesthesia workstation.
This is the workstation. Check for any leaks in the workstation. Check for oxygen and nitrous gas flows. Arrange any one of the inhalation gas.
These are all the drugs we are using for anesthesia. This is glycopyrrolate and midazolam.
Glycopyrrolate and midazolam can be taken in a single syringe.
Pentazocine.
Pentazocine for analgesia used as 0.5 mg per kg.
Propofol.
Propofol for induction 2 to 3 mg per kg.
Vecuronium.
We routinely use vecuronium as muscle relaxant. Succinylcholine is rarely used. It is preferred when there is difficulty in intubation. And then laryngoscopes.
We need to have the two sides of blades. Number 3 blade, number 4 blade. And we need to have EG tube.
The vein circuit must be checked for any
It's
leaks.
called vein circuit. So we are performing the general anesthesia case.
This is a case of 36-year-old female came for tubectomy.
See, after shifting the patient, we need to secure the IV cannula.
And connect the cardiovascular monitors to the patient and assess the vitals. I would like to do a quick PAC before intubating the patient. I will find the NBM status, any comorps like diabetes, hypertension, thyroid problems, seizure attacks, any asthmatic history, any medication history. I will quickly review the lab parameters and look for ECG, and at last I will auscultate the patient and it's good to go.
First, the patient position is very important. The patient level should be at the level of umbilicus. Before intubating, we need to explain the patient what are all the procedure we are doing.
Now I am going to do pre-oxygenation. It can be done for 3 to 5 minutes. This is an universal mask. It can be used both for pediatrics and adults. While the pre-oxygenation is going on, I would like to give the drugs in the order: glycopyrrolate, midazolam, pentazocine and propofol. After giving propofol, the patient gets unconsciousness and goes to sleep. After that, the mask should be held tightly onto the patient. When I feel I was able to ventilate, I would like to give vecuronium and start bag and mask.
Now I am giving muscle relaxant. The mask should be held like this. C E shape. See, this is the C part, this is the E part.
The thumb and index finger form C around the mask. The middle, ring and little fingers form E along the mandible. The 3 lower fingers lift the jaw upward to maintain airway patency. After 3 minutes of pre-oxygenation, I will position the patient. I will place the head in sniffing position. That is, neck flexion with head extension. Use the right hand to open the mouth. Hold the laryngoscope in left hand. Insert the blade from the right side of the mouth, sweeping the tongue to the left. Advance until the epiglottis is identified. Place the tip in vallecula. Lift the laryngoscope upward and forward along the handle axis. Apply a gentle pressure over trachea. We can visualize the vocal cords and the glottic opening. They are in abducted state. Pass the ET tube through the vocal cords under direct vision. Advance until the cuff is 2 to 3 centimeters beyond the cords. Inflate the cuff with the minimum volume required to achieve a seal. For confirming the tube placement, observe bilateral chest rise. You can auscultate for both the lungs and epigastrium. It is called 5-point auscultation. Confirm bilateral equal air entry. Secure the tube by attaching the plasters around the angle of the mouth and position the patient for surgery. Set the oxygen gas flow to 2 liters per minute and the nitrous to 3 liters per minute. After positioning the patient, start the ventilatory mode in workstation. Set the parameters like tidal volume, respiratory rate, PEEP. Observe the delivered tidal volume, minute volume and FiO2. Watch for bellows movement. Monitor the vitals. Also observe the chest rise of the patient intermittently. Give the maintenance dose of muscle relaxant when you observe the efforts from the patient. For extubating the patient, we use the reversal myopyrrolate, that is neostigmine and glycopyrrolate. Before extubating the patient, cut off all the inhalation gases and nitrous. Do a gentle ET tube suction and then do the gentle oral suctioning of the patient. Before extubation, ensure that patient is awake or adequately responsive, like opening the eyes, following commands, and there should be adequate breathing For that, check for tidal volume. Feel for the gush of air from the ET tube. It is the confirmatory sign that patient can breathe on her own. Also check for the tongue movement and observe for the saturation. While placing the suction catheter in mouth, deflate the cuff completely, remove the tube smoothly at peak inspiration or during positive pressure breath. Ensure that the patient is breathing on her own and obeying commands. Check for the cough reflex, hand grip and head lift. Apply oxygen via face mask and observe the patient for 5 minutes, as there can be chances of extubation complications like laryngospasm, bronchospasm, airway obstruction.
This is my 300th intubation. Thanks for my guide, Dr. Madhusudan Reddy sir, for boosting my confidence in doing a GA case, managing a GA case. I have been exposed to many kind of difficulty intubation. Many more to go, many more videos to come, many more techniques to educate you.